So thank you for everyone for joining us. We have Dr. Margaret Flowers with us to continue. Allison just joined. Um, to continue our Young Greens education calls. This week we're going to talk about single payer healthcare. Um, and we're going to have Margaret. Margaret's got a slideshow, and she's going to talk about her work for a little bit, and then we will open up the questions and go from there. Brendan, do you want us to do a kind of roll, or at least maybe ask the phone numbers that I see?
That would be great. I've got everyone listed who's listed, but those numbers, if they want to introduce themselves, that would be great.
Okay, so yeah, I've got 207604 number. That is you. Could you let us know who you are and where you're from?
Hi, this is Lynn, and I'm from Maine.
Hey, Lynn. Next, I have a 330310 number.
Hi, this is Ken Sanders with Ohio Greens.
Okay. I've got a 410591 number.
That's me.
Margaret? Okay, cool. So we've got Margaret twice. And then I have Allison Biddick, Brendan Phillips. I have an Ian. If you want to tell us where you're from. I have a Kevin Hatfield who I can see.
Yes, from Georgia.
Yep. And then a Tim. Cool. So, real quick, some features on Blue Jeans. I will mute everybody when Margaret is talking. That way we don't have crazy echoes and all of that kind of stuff. We can always pretty much have a constant stream of communication in the chat on the side. When I unmute people, a cool feature that I learned on our last call was that if you are muted, as long as you hold the space bar, it will unmute you. So you don't have to go through the process of clicking and unclicking and accidentally muting or unmuting yourself. If you hold space bar down, it will unmute you. So that's a nice feature. The Young Greens is a explicitly youth space. So we're going to, in our stack, we will try to do a progressive stack that orients towards youth and people of traditionally oppressed communities and those who haven't spoken. So we'll try to use a progressive stack as best we can to make sure more voices are heard. And whenever I'm going to be taking stack, so I will try to provide in between speakers a space for people to get on stack. And then people can also use the chat on the side, and we'll see how that works. Brendan, Allison, steering committee members, if I am not seeing something happen in the chat, I've got my phone right next to me, so shoot me a message and I can deal with a question there or somebody who's trying to get on stack from there. Are there any questions before we start? Okay. Well then, Margaret, I will go ahead, mute everybody, and you should be unmuted. Can you talk? Will it let you? Nope. 1 second. Okay.
Okay. Can you hear me now?
Yep.
Great. Well, thank you so much for inviting me to be on your call and inviting me into this space. Chris, are you going to put the slides up on the
Yep.
screen? Okay. I kind of divided the talk into 3 sections. One is going kind of through a little bit about our healthcare system, and then about what a single-payer healthcare system that we advocate for would look like, the legislation that is out there, and then I was going to talk about advocating for it. And I'm happy to take any questions, and if you want to stop me, you can stop me, or if Chris, if you want to stop, take a break during the presentation and take a few questions, we can do that too.
Okay.
So great. So I see the slides. Let's go to the second slide. And yeah, we'll wait for that to load. Basically, this comes from the Organization for Economic Cooperation and Development. OECD does a yearly kind of health report. It's really helpful to see the statistics they put together. I like this bar graph because it lists the countries on the left-hand side that have healthcare systems, and then, or some of the top OECD countries. And then it shows you how many of them are 100% universal. You'll see all those 100s starting at the bottom and going up. And it also shows you the mix of countries that finance their healthcare systems through public financing versus private. And the United States, which is the 4th one from the top, is an outlier in a few respects, in that being the wealthiest nation in the world, we still have a large proportion of our population that does not have coverage. And we also have such a large proportion of our population that's covered with private health coverage. And so that's part of our problem. Let's go to the next slide. I often say that we're the only industrialized nation that really uses a market-based system for healthcare. This slide is a couple of years old, but the relationships stay the same. It's just that the total spending goes up in the U.S. It is, I think, over $10,000 per person per year that we're spending on healthcare total. So if you look at, the United Kingdom, Japan, France, Canada, other countries that have universal systems, you'll see that not only is the U.S. spending much more than they are in total spending, but in many cases we're spending more than twice as much as they are, and we're already spending more in public dollars alone through various mechanisms of taxes, our public health insurances, subsidies, and things like that. We're spending more in public dollars per person per year than most other of these countries do, and they have universal coverage. Let's go to the next slide. And why are we spending so much? One part of the problem is that we have a multi-payer system. It's very complicated. And this shows the growth. On the bottom line is the growth of physicians over time, and the red line is the growth of administrators. And you can see that coming into the managed care era, and then really going in gusto with private for-profit insurers, we have a huge administrative burden. And you'll see on the left-hand side that that's 3,000% growth in administrators. And this is all this different paperwork and stuff that has nothing to do with actual healthcare. Means that we spend more than around a third of our healthcare dollar on administration. And that's about, I've seen estimates anywhere from $450 billion to $700 billion a year. That's just on administration. Let's go to the next slide. And what do we get for that? This is a slide looking at over time at the number of people who are uninsured. And you can see that we were really heading into a crisis going into the healthcare reform process of 2009, 2010. And then the Affordable Care Act was passed in 2010. And the number of people without, insurance started to drop off. But that has hit kind of a plateau phase, and that's not expected to change significantly. Now, this was actually based on data before President Trump was elected, and over the past year alone, 3.5 million people net have lost their health insurance, primarily because of premiums rising and not being able to afford it. And I think with some of the changes that have been made recently, we can anticipate that the number of uninsured is going to start to go up, significantly. And this is pretty consistent with what we've seen at the state level. Every time there was a sort of a big universal health reform done at a state level, we saw a drop off in the uninsured for a short time, and then it leveled off and started to rise, and ultimately those systems failed, and we predict the same thing will happen at the federal level because we're trying to operate in this market-based system. Let's go to the next slide. And I just wanted to remind everyone about incomes and wages. So mean family income for each of the fifth kind of percentiles. So you can see the bottom 20% is that pink line at the bottom, and that stayed pretty stagnant, as have the other sections on this. The only one that's really rising is the top 20%. And so while we see health insurance premiums rising by 5, 10, 20, sometimes 40% in a year, we see out-of-pocket costs rising significantly each year, so that families have to spend, thousands of dollars in deductibles before their health insurance kicks in. All of this is happening while we see a flattening, of family income. And so it's each year it creates a bigger burden for families to pay for their health care. Let's go to the next slide. And that's why we see that medical illness is the #1 cause of personal bankruptcies. And the most people who go into medical bankruptcy actually had some form of health insurance when they started their illness. So we think of health insurance as an umbrella that melts in the rain. When you need it, it's not there for you. Let's go to the next slide. So what is the Affordable Care Act? It's interesting, and I think it illustrates how much this is politics and not policy, is that the Affordable Care Act is really a model that came out of the Heritage Foundation and was passed in Massachusetts in 2006 by Governor Mitt Romney, a Republican, and then was taken up by President Obama as the model for the health legislation that he pushed forward. And so suddenly you see now the Republicans hate it, the Democrats love it. If it had been Mitt Romney that was elected president, we probably would have seen the complete different scenario. Medicaid expansion for those at the lower end of the income spectrum. Everybody else has to purchase private insurance. We use our public dollars to subsidize the purchase of that private insurance. Those dollars go directly into the pockets of the health insurance companies. And then in return, they're supposed to accept more regulation. So saying that they had to cover people with pre-existing conditions, saying that they had to cover certain essential benefits. That was a trade-off by basically not only guaranteeing them customers, but the government actually setting up markets and hiring people to sell their insurance for them. For the next slide. And another interesting thing about the Affordable Care Act is it actually codified into law a class-based system or a tiered system. So there were 5 tiers of coverage: platinum, gold, silver, bronze, and then catastrophic. And now they're adding another one. It's being called a copper. And basically, the lower tier plans cover less and have higher out-of-pocket costs. So we had a tiered system before, kind of de facto, but now it's codified into law. And then at the bottom, I wrote narrow and ultra narrow networks because what private insurance companies did is, although we required them to cover people with pre-existing conditions, they just really shrunk down the number of health providers in their networks and also cut out major medical centers. So people with actual health problems may struggle to find a provider in their network. They may struggle to find, if they have cancer, they can't go to the cancer center. That's not covered. They have to pay for it out of pocket. So the insurance companies, they always find a way around the regulations that we give them. Okay, next slide. So the way that I usually talk about the current system is that it's a market-based system. The United States is an outlier for having a market-based system, and we have a market failure. It's the most expensive. I didn't go into it, but our health outcomes are poor compared to other countries. We have increasing health disparities, particularly for, oppressed communities. We have the highest number of preventable deaths of the industrialized nations. we're losing our doctors because of the system. Physician burnout was considered our second greatest problem last year behind opioid addiction. And we have a number of people that are uninsured, but also a lot of people who are underinsured. They have health insurance, but they can't afford to use it. Go to the next slide. Another interesting point that was made about the Affordable Care Act is that it became kind of this new model for social insurance that was considered to be progressive. And so the article, which is cited down at the bottom, there's a quote from it that says, if Obamacare, built on means testing, privatizing, and decentralization to the states, is treated by progressives as the greatest liberal public policy success in the last half century, then how will we be able to argue against proposals by conservative Republicans and center-right neoliberal Democrats to means test, privatize, and decentralize Social Security and Medicare? And that's actually, what we're starting to see. President Obama was pushing Myra. It didn't really go very far, but it was changing Social Security into, investment, a financial tool on Wall Street. We're seeing cuts and changes to Medicare that are driving it to be more privatized. Let's move to the next slide. So what is single payer? I generally refer to it as National Improved Medicare for All. That's the particular model of single payer that we've been advocating for. And there are other models. We could go with a completely socialized national health system like the United Kingdom has, or like we have in our own Veterans Administration. But the kind of movement for single payer has decided that the compromised position of a National Improved Medicare for All may be more reasonable or more acceptable. I think that's debatable. But that's something we could talk about. But basically, it's a unified risk pool. It's a universal health system that every single person is in. Everybody contributes into that system based on their ability to pay. So those at the lowest end of the spectrum would actually not pay at all. Those at the higher end would pay a higher proportion. All medically necessary care would be covered. It's really important that the coverage be comprehensive, because having a single system that covers all medically necessary care means that we can have the simplest administration, and that saves a lot of money. If we just have one system that covers everything, one set of rules, it's easy for people to use, it's easy for health professionals to navigate, saves a lot of paperwork and a lot of time. And actually, physicians are now spending 2 hours of time on paperwork for every hour of patient care, which is outrageous and means that they spend less time with their patients. It means that every health professional is in the system, and so patients have their choice of where they go to seek care. If they need to go to a medical center that's outside of where they live because it specializes in their condition, they can do that because it's a nationwide network. And it allows health professionals and patients to decide on what treatment they receive, not insurance company bureaucrats. It also allows us to really have a health system where we can prioritize preventative care. We get rid of barriers to care. And actually, I forgot to put it on here, but we advocate for no cost at the time of service, no out-of-pocket costs, because those only serve to be barriers to people actually getting care when they need it. And then finally, we advocate for a system that is transparent and accountable to the public. And I didn't put it in here, but also a mechanism for the public to participate in helping to shape that system. Let's go to the next slide. So we have a bill in the House and a bill in the Senate. HR 676 has been introduced in the House since 2003, every session, and it's the lead sponsor on that is Congressman John Conyers from Detroit, Michigan. And in HR 676, if you want to read it, it's a very short bill. It's easy to read. I recommend it. And I'll tell you where you can find that later. But basically, it's a universal system. All residents are covered. It's paid for through a progressive tax. And you can see the list of benefits. It's very comprehensive. And so patients have choice of where they go for care. Let's go to the next slide. And there have been a number of studies looking at single-payer systems at the national level, also at the state level, and for the last actually almost 30 years now, we've had these studies, and they all pretty much find the same thing, that the additional costs of having to cover people who are uninsured or poorly insured, the cost of getting rid of co-pays and other out-of-pocket costs is offset by the savings that we get from a much more simplified administration, being able to bulk purchase drugs and equipment so that we can negotiate with pharmaceutical and other companies for realistic prices for their goods, reduce physician office costs. Physicians spend a high amount of their overhead on billing, reduced administrative costs of insurance, and being able to put more of an emphasis on primary care and reduce fraud actually means that if we put the system in place, we can be saving money each year instead of what we're seeing right now where our healthcare costs are really skyrocketing. This is consistent with the most recent country that adopted a single-payer healthcare system, which is Taiwan, adopted one in the mid-1990s. Their healthcare costs were rising by, I think, 13 to 15% each year. And once they adopted a single-payer healthcare system after the first couple of years of adjustment, they really slowed the rise of their healthcare costs. All right, let's go to the next slide. In the Senate, Senator Sanders introduced S-1804, the Medicare for All Act, in mid-September. He was very reluctant to introduce a single-payer bill. He announced to the single-payer movement last fall after the election that he was not going to introduce single-payer, even though he had campaigned on it during his presidential run. People pushed back on that and said, no, this is the time you need to introduce that. And he received a lot of pressure, and he finally agreed to introduce a bill. We had pushed him to introduce a companion to HR 676 and also to make it a strong bill and not water it down in order to get more Democrats to sign on to it. And sadly, in the last few weeks before that legislation was introduced, he really kind of threw some things out in order to get more Democrats on board. There are 16 co-sponsors for that, plus Senator Sanders. And so it has some significant weaknesses, and I wanted to list those here. So one of the things that's not comprehensive, it excludes long-term care, and for families and people who have needs for that long-term care, this is a huge burden. It also includes some copays for pharmaceuticals. It allows for-profit providers, and we'll talk about that a little bit more later, but what we're really seeking to do in our healthcare system is to end the treatment of healthcare as a commodity, and that doesn't happen in this bill. And then on top of that, doesn't have the budgetary controls that HR 676 has. So imagine that you have for-profit health institutions and they have a guaranteed payer through the government, and they don't have any way to keep them from abusing that. It has a very prolonged and complicated transition period of over 4 years. HR 676 calls for everyone to be in the system on a certain day, and that's how other countries have done it. That's how we did it with Medicare in 1965. And then finally, the last one's a little bit kind of wonky, but there's something called MACRA that was put into the Affordable Care Act, which is a payment model that partly it's, physicians can choose one of two things. One is pay for performance. So they get paid if their patients do well. And this is it's been found to be a bad incentive because it incentivizes physicians to kick patients out of their practice if they're not improving. And then the other is it uses these kind of different payment models that have been proven not to actually work. So we were sad that he kept that in. Let's go to the next slide. I guess I wanted to go into more kind of like talking about how we get a single payer system in the U.S. Do you want to stop here, Chris, and see if anybody has questions?
So I'm going to open up a stack. We've about doubled our participants since the beginning of the conversation. So if you want to get on stack, go ahead now and say stack in your name, and we will do our best to get everybody covered. So does anybody want on stack before we kind of get into more action-oriented conversation to talk about, just the beginning part of this presentation? So if you want to get on stack, go ahead and unmute yourself and say stack in your name.
Allison Stack.
Okay. Anybody else?
Lynn Stack.
Okay. So Allison and I will stop between people. So if anybody wants to jump on after kind of hearing some contributions from others, go ahead, Allison.
CMB Stack.
Who is that?
Corey Stack.
Corey.
Corey. Okay, and if you're not talking, go ahead and mute yourself. You can do it on the side, and then a cool feature of Blue Jeans is to unmute yourself to say something like Chris Stack. You can just hold spacebar, and as long as it's held, you'll be unmuted. That way I don't have to try to track down where echoes are coming from and stuff. Go ahead, Allison.
So in general, I mean, this, like HR 676 or whatever the number was, it seems pretty crappy, but I mean, compared to what we already have, it's kind of an improvement. So would you advocate that we contact our elected representatives to have them support this bill? Does it have any actual shot of passing? I've been, I haven't had health insurance in a long time, so I'm kind of out of the loop on this. So what would you, like someone who's in the Green Party or someone who does activism, what would you recommend them do concerning this particular bill? Or should we more focus on advocating for an actual universal single payer system? Over.
Okay, sure. So HR 676, which is the House bill that's been introduced since 2003, that actually came out of the single payer movement and was, the provisions in that bill are what kind of people in the movement advocated for. So we do support that. It would be a universal system. Every person living in the U.S. would be in that healthcare system. It's the Senate bill, the Sanders version, that has a lot of weaknesses. And our campaign, which is Health Over Profit for Everyone, and I'll go into that more at the end too, we're not supporting the Sanders bill. We see it as a tool that people can use to meet with their senators, but to meet with them to actually talk about what it is that we want to see in that legislation. And we're also still, through the Health Over Profit for Everyone campaign, working with different kind of constituencies to really define more specifically what their needs are and what they want to see in the healthcare system. And in the second half, I'll talk a little bit more about why that's important.
Okay. Does anyone want to get on stack before I go to Lynn? Go ahead, Lynn.
Maine, we're running a gal for governor for 2018. So when she talks to people, it would be better for her to copy the HR 676 instead of this awful Sanders thing, correct? Because we keep saying Medicare for all as if it's interchangeable. And
right.
From what I'm hearing, you folks saying it's not at all.
Right, yeah. Now, as a governor, we advocate for a national health program, not state-based single payers, and we can go into that if you have questions about that. But that's a whole other discussion. So, as a governor, it really wouldn't be a state thing, but it would be great for her to just say, yeah, that this is what the solution is.
Well, actually, in Maine, we have some groups that are nonpartisan. They tend to be heavily Democrat, but they are nonpartisan, and they are trying to get universal health or Medicare for all, whatever they want to call it. I'll have to read their junk now. We are trying to do something in just Maine. So we may be a prototype, so I want it to go correctly.
And that's the thing, is that there have been a lot of states over a lot of years that have tried to do things at the state level. There are ways that states can start to approach having a universal healthcare coverage, but it is not going to be a Medicare for all system. And so we have to be careful that we don't call the state efforts a Medicare for all system, because they're not going to have the same ability to control healthcare costs that we can at the national level. And so if they fail because of that, then we don't want people to think that we can't do Medicare for all at the national level. There's just a lot of hurdles at the state level because our system is so complicated, and our state systems get both federal and state funding.
Okay. Well, we'll have to read and be careful how we speak.
Right. Yeah.
Yeah.
Thanks.
I've got Corey next. Does anyone want to get on stack before Corey starts speaking?
Kenny, Stack.
Kenny? Yep. Go ahead,
Cool.
Corey, and I got Kenny.
Yes. Well, first, can everybody hear me?
Yep.
Yes.
Okay, cool. I'm at work, so I just wanted to make sure that was working. My question is, so you briefly touched about, I know that the conversation is about specifically single-payer healthcare, but you touched on the opioid crisis and the other, I guess, it's not an epidemic, that's not the word I'm looking for, but there's the movement to legalize cannabis for medical use, at least at the national level. And it seems like right now, in regards to veterans and others suffering from PTSD and other people that are being treated with opioids and then later abusing them, and I guess these problems seem to be somewhat correlated. Is there a way that we can, either through legislation or through shared movement, start organizing or create a bill that more effectively addresses the opioid crisis, presumably legalizing cannabis to help reduce that, as well as achieve a national single-payer system?
Right. Interesting question. So, when I look at the opioid epidemic, a lot of that is connected to having a healthcare system that's based on profit. And we know that a lot of these pharmaceutical companies that make OxyContin and these other narcotics are actually, flooding markets in states like Ohio and West Virginia. And there's this whole predatory nature to that, the way that the clinics are set up anyway, that's kind of one of the symptoms of why having a healthcare system that's based on profit instead of health is a huge problem. Once we create a healthcare system like a National Improved Medicare for All that makes the bottom line health and not profit, this is why it's so important to get that commodification of healthcare out of there. Then you can start, and we see this in other countries, you start looking at policies that actually improve the health of the population. And so things like cannabis, which I think is a very important treatment that should be available to people, and people have a way to participate in that system and push for what they want to have in that system. It just really kind of turns things on their head. I see moving to a National Improved Medicare for All as like a first step in that process to get the profit out and get everybody into the system. And then we have a mechanism to start really pushing and continuing to shape that system to make it the best that it can be. Now, we don't have to wait for National Improved Medicare for All system to push for, medical cannabis. And actually, my partner, Kevin Zeiss, has been involved in that since 1980. And he would be a better person to speak about that than me, if you want to talk about that further.
Okay. I've got Kenny next. Anybody else want to jump on stack? Go ahead.
Okay. Hi. So, Margaret, you mentioned earlier that the administration costs in our healthcare in America have rose a lot, and I think you said it was somewhere around like 500 billion. And the Green Party being pioneers of universal healthcare and everything, I wondered, is there a plan that we have during the transition from our multi-payer system to the single-payer system, how do we address maybe job loss? I wonder how much of that 500,000 will be dissolved. How many of those jobs are jobs for people to get paid and everything? How much of that 500,000 would we whittle off? How many people would lose their jobs? How much of that money would dissolve with their jobs and everything as we transition into single payer? Is that something that the Green Party is kind of in control of?
It's a great question, and I'm glad you asked that. In HR 676, the House legislation, it actually provides for people who are displaced from their job because of the new system, they are prioritized to be hired into the new system, and if they aren't hired in, then they get job training and income support for 2 years. It's an interesting situation where, and I saw this, it's actually part of the reason I left practice and started advocating for a single payer healthcare system, is that I saw so many people that I knew through medical school, just through being a physician, who were leaving practice because of their frustration with the system and going into these administrative jobs. It's much easier to be just a medical director and work 9 to 5 and never have to be on call. And so there's a lot of people who left the system because of their frustration with it and went into these administrative positions. We have a huge need for direct patient care, and nurses have done the same thing. Nurses have left and gone into administrative jobs, and so I see that actually a lot of the shortage that we have right now, if we move to a single payer system, hopefully more people would want to come back into actually providing direct patient care, which would be a good thing. The Sanders bill provides some transition support for workers, but it's capped at 1% of the spending of the whole system, and I don't know that that is actually going to be adequate. So HR 676 is not capped. But as far as the Green Party, I think it's just important for us to be clear that, in everything that we talk about, as we transition to a new green economy or whatever, or transition off of a war economy, there has to be a just transition for workers.
Right on.
Okay, do we have anybody else that wants to get on stack before we kind of move on towards more action-oriented part of the presentation and discussion? So anyone else on the basics of what we have now and the options on the table? Okay.
Great, thanks. And I'll give you some resources at the end too, but we can go back to starting.
Awesome.
PowerPoint. So first off, sometimes it helps to kind of cheer ourselves on and recognize that we can do this. Every other industrialized nation has a healthcare system that treats healthcare as a public good or a human right. As I said, they spend less than we do. Most spend less than half. They have lower death rates, more accountability, and higher satisfaction. And no country so far has adopted a single-payer system, found it to be worse, and switched back. Let's go to the next slide. So how do we get a healthcare system, a universal healthcare system in the United States? In 2009, 2010, during the health reform process, I was in Congress. I was volunteering as what was called a congressional fellow for Physicians for National Health program. And so I was very deeply involved in that process, trying to push single payer. And at the end of that experience, I came away with 3 basic lessons of what we needed in order to win this. And the initials are ICU, so I often say we have a healthcare crisis and we need the ICU. For anybody in healthcare, that stands for intensive care unit. So it just makes it easy to remember. So the I stands for independence. In terms of advocating for a universal healthcare system, we need to be independent of the kind of political agendas of political parties. Now, as the Green Parties, we don't have to because it is part of our platform. But I saw too many people tying the legislation to the legacy or, the electability of politicians and not to what we actually need. We also need the C, clarity. We have to really understand what it is that we're advocating for, because we understand that most of the forces are aligned against us. They're going to try to weaken it. They're going to try to water it down. They're going to try to tell us that things are something that they aren't. And that's what we saw during the Affordable Care Act, where they were selling it as a universal, guaranteed, affordable legislation, and we knew that it was never going to be any of those things. So we as the advocates have to understand what we're advocating for. And then the U stands for uncompromising, because every movement that has advocated for major transformative changes has been told that they're advocating for too much and that politics is all about compromise and you just need to give in. But when they're telling us to compromise on something basic like this, they're basically trying to take our power away. And so we have to be more persistent and uncompromising in that demand. So remember ICU. Let's go to the next slide. So I wanted to, in terms of talking about compromise, go through just a quick little bit of history of health reform in the United States. People have been advocating for some form of a national health insurance for the last 100 years. And there's a Professor David Barton Smith, who was at Temple, now he's at Drexel, who writes about this. And he divided those 100 years into 5 phases. And he called each of those phases a compromise or a more palatable approach that was more considered to be more politically feasible, but none of those compromises put us onto track of where we need to be. And he writes about the fact that the basic conflict throughout that 100 years is whether healthcare should be a public service or whether it's a commodity. And I remind people that it can't be both. So if you have somebody who's saying that healthcare is a human right, but they're saying we have to fix the Affordable Care Act, then they're confused, because the Affordable Care Act treats healthcare as a commodity. When healthcare is viewed as a public good, there's a sense of social solidarity. Everybody is in the system. They want it to be the best system it can be. The interesting thing psychologically is when we treat healthcare as a commodity, people don't want to pay for more than they need, or they feel like they're being ripped off. And you see this all the time kind of in conservative talking points where they say, I don't want to pay for that lazy person who smoked cigarettes and got cancer. I shouldn't have to pay for that. And that's what happens when it's treated as a commodity. It kind of isolates us and makes us compete with each other. Let's go to the next slide. And so what we're seeing right now, and it was interesting at the end of the summer, after there was an effort, all throughout the beginning of the year and through the summer to repeal the Affordable Care Act. And all during that time, there was a strong groundswell for national improved Medicare for all. As soon as that summer break started in August, we suddenly saw all these kind of prominent people coming out and saying, I support single payer, but we can't, it's too much. We should do these other things. There'll be steps to single payer, things like a public option or lowering the age of Medicare or allowing people to buy into Medicare. And first of all, none of those proposals are going to solve the problem. But this is just another attempt to kind of take us off track and to make us think that we're asking for too much. And so we need to be able to resist that. And so I just wrote up, some of the reasons why these various incremental proposals that are being proposed are not effective, just to help, for you if you need to talk about this, and hopefully the slides will be available. I've done a whole talk on this, so I kind of consolidated that down into a few slides. If we do something less than the single payer system, we give up 84% of the savings, administrative savings that we would have if we went to a single payer system. So it's, we give up a lot of dollars that we could use to pay for care. When we have systems that are opt-in as opposed to putting everyone into the same system, at best you can achieve about 85% coverage. The effort of going through and creating these compromise systems like a public option would be about the same as what it would take to create a Medicare for all, but they would benefit fewer people. If we went to a public option plan, adding one more public insurance into the current mix of insurances that we have it would attract basically people who have healthcare problems, and we would call this a high-risk pool, and would suffer under the burden of having to pay for a lot of healthcare needs, and then they fail. This has been shown over and over again. And when a public option fails, because so many people are confused and think that a public option is a government single-payer system, they would interpret that to mean that single-payer systems don't work. If we go to just one of these incremental steps, it doesn't actually solve all of the other problems that we have with our health system. It just adds more complexity. And every time we've tried to regulate private insurance, it's failed. So we know that we just can't include them in our system. Employers actually, so a lot of these public option plans that were floated out were ones that would be offered to employers. And employers really just want to get out of the business of having to provide health insurance. They list it every year as one of their greatest problems, especially small and medium-sized businesses. So we want to break that link between employment and health insurance. And if we were just to go with one of these incremental proposals, it does nothing to end the tiered system that we have right now. So I'd be happy to make that other whole talk available to people if they're interested in learning more about this. But basically, the point of this is that, taking a smaller step than going to a universal single payer system is just not going to work. Let's go to the next slide. So this is, when people say we should compromise, some of the arguments that or responses that we have to that is that the National Improved Medicare for All system is the smallest incremental step that will move us on the path to a universal healthcare system and solve our healthcare crisis. That when people say it's too much, Medicare itself was created in less than a year as an entirely new system without using any computers. They enrolled 19 million seniors into that system. We're already paying for universal comprehensive health care, so if we don't do that, why are we spending this much money and not covering everyone? Single-payer healthcare systems around the world and in the U.S. are well studied and proven to work. We already have detailed proposals over the past number of decades. There have been many articles published in peer-reviewed medical journals talking about how we do this. This is countering the argument we often hear where people say, oh, those people want single payer, but they're all pie in the sky. They haven't actually figured out how it would work. And we have a lot of detailed proposals that would show how it works. We have models of single payer in the United States, our traditional Medicare and our VA system that we can use, to show how these systems work. And another argument that's put out there is that other countries have private health insurance in their systems or have moved to privatize their systems, and all of the countries that have allowed privatization into their systems have seen higher healthcare costs and declining satisfaction and more difficulties in obtaining care. So just some responses there for you if you start to run into people that say we're asking for too much. All right, next slide. So people say that it's not politically feasible. We have to remind ourselves that feasibility of reforms depends on the political winds, and that's something that we have the power to change as people. I've seen this in a number of fights that I've been involved in, from fighting for net neutrality in 2014 when we were told that that was impossible, to stopping the Trans-Pacific Partnership, a huge trade agreement we were told we couldn't stop, and we did. So we know that when we organize, we can change what's politically feasible. A single-payer system is really the only kind of solution, that or socialized type of healthcare system like the UK, that will actually solve our healthcare crisis. So people may say that certain things are politically feasible, but they're not really practically feasible if they don't solve the crisis. We already have a majority of public support and health professional support for Medicare for All. Business leaders are coming on board now, even conservatives coming on board, seeing that this is necessary. There have been a number of articles talking about how even the most capitalist countries recognize that healthcare doesn't belong in the marketplace. When we advocate, we know that people are inspired and motivated to fight for something when it's actually a bold solution, something that they want. And so these lackluster solutions just don't get people to turn out. And there will always be opposition to health reform, no matter what we're advocating for. So our best strategy is to present something worth fighting for. President Obama, decided to compromise from the beginning because he didn't want to have the same fight that the Clintons had in the 1990s. And of course, his plan, even though it wasn't, was called socialism, death panels, all this, stuff. No matter what we do, we're going to face that. So we should put forward something that we want to fight for. Let's go to the next slide. This is another quote from David Barton Smith, and he reminds us that the practical mechanics of how to make a universal health insurance system work is a lot easier than trying to patch together the current system that we have. Medicare has been around for a long time, and people want it, they like it, and polls show that even conservatives have a strong support for Medicare. And now, because of the Medicaid expansion, there's even strong support for Medicaid. And I've seen this myself when I'm out talking to people across the political spectrum. Nobody wants their Medicare to get messed up. So this is why we advocate for that. Let's go to the next slide. So how do we talk about single payer? One of my mentors was Dr. Quentin Young. And he always reminded us that we need to focus on the elegant simplicity of single payer. And if you look at the cartoon there, you see, all of this hodgepodge on the left-hand side, and then just this single payer. It's simple. It's one system. Everybody's in it. So when I'm trying to explain to people what I mean by a single payer system, National Improved Medicare for All, I just kind of break it down and say it's a national system. Every person living in the U.S. and every health professional is in it. Wherever a person goes around the country, or in our territories, they're going to be in that system. And it's from prenatal care through death. It's improved in that the care is comprehensive, or the coverage is comprehensive. It includes all medically necessary care. And we advocate for long-term care and no copays or deductibles. And like Medicare, it's financed up front through a progressive tax, so each person pays according to their means, not their health status. All right, let's go to the next slide. And there's just a couple more. Now is the time. As I've said it already, we're spending twice as much on healthcare per person, and still leaving tens of millions of people out or underinsured. We're wasting hundreds of billions of dollars every year in excess costs and overpayment to pharmaceuticals. So that's $500 billion estimate for administrative costs and about $100 billion overpayment for pharmaceuticals. This is more than enough to offset the cost of coverage, comprehensive coverage for everyone. Why should we keep paying for more and sacrificing people's lives to ensure profits for health insurance? And for those who believe that we should have something less than universal coverage, we ask who should be sacrificed, who should be left out. Next slide. So I think okay, just two more slides, I think. There is no backdoor to National Improved Medicare for All. Remind yourselves that when people say that we can just do this other easier thing and it will get us there. We have to be prepared to face opposition because we're on the right side of history. Social movements are always told they're asking for too much, but we have the power to change the political culture so that the impossible becomes inevitable. We need to educate people about this, do outreach, mobilize people, and escalate our pressure over time to win. And part of the reason that I moved from advocating just for single payer into a broad range of issues is that all of these issues are connected. Healthcare is connected to everything that we do. It's connected to the food we eat, the water we drink, the air we breathe, the jobs we have, how much education, if we have a home, if we're safe in our communities from violence. All of these things impact our health. And so all of these can unite us in fighting for a healthcare system that serves our needs. Let's go to the next slide. So just finally, for Green Party, members, I think that this is one of the many issues, but this is a very important one right now. That's it's one of the top issues that people are concerned about. That really differentiates us from the other parties. We are the only political party other than the Socialist Party that has single-payer health care in its platform. So I think it's really important for us to use this as an issue that differentiates us from the other parties, and also is important that we get out there and start leading the way on this. Right now, Democratic Socialists of America are very active on this issue, a lot of social media on it, and I feel like this is an issue that we as Greens should really be owning. So what can you do? We have a campaign called Health Over Profit for Everyone. It's healthoverprofit.org. And this is made up of some of the strongest single payer advocates that I know around the country who wanted to have a campaign where we could actually have the flexibility to do what is necessary to fight for this system. So many of the groups, like just typical groups that are involved in advocating for this have certain restrictions of what they can do, and we wanted a group that didn't have those restrictions. So that's HOPE, Health Over Profit for Everyone. We do national calls on Monday nights at 9 o'clock, and you can sign up for those if you're interested in learning more. It's bit.ly/HOPE calls. We have a lot of tools pages that will help you to organize educational events in your communities. There's a lot of movies that you can show to educate about this and do discussions afterwards. There are, single payer advocacy groups in most states, so there are often speakers that you can invite to an event. We have a Tools for Education page that has all kinds of charts and one-pagers and things that you can use to hand out. We need to be organizing actions as well as attending actions. And this photo on the right is actually a march that we did in Baltimore a few years ago. And the person that you see is second from the left with the green shirt on is a prominent member of our Green Party, and he's out there leading the way of that march. So we need to both organize actions and show up for other people's actions and show that this is an issue that Green Party members are active on. We need to be pressuring our legislators. And if you're running for office, I encourage you to make this a real centerpiece of your platform. So our website's at the bottom, and then also our Twitter handle is there as well. But if you go to the HOPE website, you'll find a news section that we update fairly regularly. You'll find the various tools pages. We have an action map, and we have action tools that people can use. And we really have this campaign to be in service to the movement. So if there are things that you need that aren't there, let us know, and we'll try to create those materials. So I'll stop there.
Okay. Okay. Thank you, Margaret. Thank you, Margaret. Moving forward from there, do we have any question? Anybody who wants to get on stack following that portion?
Brendan's stack.
Who was that?
Brendan.
Cool. Anybody else? Go ahead, Brendan.
All right, thank you. So the answer to this question is probably fairly obvious, but I'm going to ask it anyways. When you lay all of this information out, it seems fairly obvious. So why aren't more of our lawmakers supporting this?
And that's because of the lobbyists and the dollars that come in from the industry, and we saw that very clearly during the ACA fight. And so even though, like right now, we have 120 Democrats on the House bill and 16 Democrats plus Sanders on the Senate bill, we know that most of them are doing this because they feel like it is something they have to do. It's not really something that they support, and many of them think it's not going to go anywhere right now, so they think it's a pretty safe thing to put their name on. And so our job is to make them do more than just put their name on a bill.
Okay. I had Allison request stack inside the chat. Does anybody else want to get on stack? And I do have the chat opened on my iPad next to me so I can see anybody who types in there. Anybody before Allison? Go ahead, Allison.
Okay. So as a 28-year-old, I lost my health insurance when I aged out at 26. And I mean, they talk a lot about healthcare with like concerning like people who are like middle-aged or older, or, you know, we have to just get to that, you know, part where we qualify for Medicaid or Medicare or whatever, that kind of thing. Do you possibly have like a guesstimate, I guess, for the number of years that are being robbed of young people when they don't have access to easy coverage, and also particularly when it comes to women not being able to access health care coverage and cancer screenings? I mean, men too. You get cancer just as much as we do. But what are the long-term effects for young people being robbed of healthcare coverage? Because that's a huge number of people who are completely uninsured because it's just too expensive, or because like they live like me in Texas where our state doesn't cover that.
That's a really interesting thought about quantifying the amount of years lost. I haven't actually seen that as a number, but I do know that in the United States, we see conditions at younger ages because of lack of access to care. So we see people in their 40s that are having strokes from high blood pressure or having kidney disease from high blood pressure. You know, we have the highest number of preventable deaths, and and I've known people as well who people with diabetes who couldn't get the care they needed and died from that in their 40s. Certainly cancer is another issue. I've had medical examiners tell me that they've had bodies that they've done autopsies on that had advanced cancer, and the person had never even sought care for that cancer. It's really disgusting that this happens in the United States. And one thing you should know is, because I'm also uninsured, is that when they wrote the Affordable Care Act with that mandate, they didn't write any enforcement mechanism for the penalty. So I have refused to pay the penalty every year. I write a letter to the IRS and I say I'm not giving any money to the private insurance companies because I know that's what you're going to do with my penalty money. And actually, in April, Trump lifted that anyway. So now the IRS sent me a thing saying I don't owe anything anyway. Yeah, but no, it's disgusting.
Anybody else for stat? Okay. So since this is the Youth Caucus, Margaret, I wanted to ask, do you have any numbers on how youth are disproportionately affected by this? I can say from my experience, I was booted off my parents' insurance before the ACA happened, because I'm a rare old youth in the caucus. Mm-hmm. But so I went over a decade without it before being forced into it by the ACA. And earlier in the call, in the first part, you were talking about prices go up 20-30%. Last year, my premiums doubled, and what I was provided for those premiums halved. So all of a sudden, I had a $400 a month, healthcare bill, which is completely out of the realm of affordability for me. That's over a quarter of my monthly income. And when I did switch, now I have a 50% copay on anything that's not just going to a doctor, and even then they still send me bills for things. So I mean, I was actually on a Green Party call once and wasn't feeling well and sat all night, didn't go to the ER because I couldn't afford it, and found out I was having a gall attack the next day after working a full day, because I also can't take off work and lose money to go to the doctor. So especially since this is a Youth Caucus call, are there any numbers? Allison's question was amazing, quantifying how much we're losing. But do you have any numbers specifically to, how our demographic is more adversely affected by this? Because in my conversations with people, I don't know a young person that doesn't deal with this, besides the few lucky ones I know who got a state job or something, and even those plans are getting shitty. So.
Mhm. Mhm. Yeah, I mean, we definitely know that it has an impact on youth, especially knowing that, wages are down, it's hard to get a job, that there's so much debt in youth. But, I'm a pediatrician, and I often think about the younger kind of, I treated 21 and less. There's definitely an impact on children. We know that uninsured children have a higher mortality rate when they're in the hospital. We know that, families delay care for their children even when they have insurance because of the out-of-pocket cost. So, but those are things that I think it would be interesting to kind of to look around and see what research there is on that, and even developing some messaging around that. Social media messaging would be important.
Yeah,
I'm actually
Go ahead.
No, go ahead.
Oh, okay, I know.
Say that you go
Digital
ahead.
delay. I was just saying, a lot of, when you get to our age of youth, there's a decent chunk that have moderate to good health insurance when they're in school. I know when I was enrolled in school, I had what would have technically been a minor surgery for $7. But that was because I was on campus at a university. But the other side of that coin, and something the Youth Caucus talks about a lot, is that, our demographic that's not getting lucky and getting health insurance out of school is often in the service industry, in places where health insurance is absolutely not provided. So I think if we're looking at those numbers, looking at the note, kind of comparing and contrasting where we're actually employed compared to, other demographics to draw a comparison would be a big part of that.
Yeah, and I was just going to look, but I won't look right now. The Kaiser Family Foundation, KFF.org, has something called State Health Facts, and you can click on that, and it often breaks things down by demographics. So it would be interesting. We should start looking at that and and see what we find there. And I was just going to say that on Friday, we're heading down to Georgia for our national conference for Physicians for National Health Program. And it's going to be focused on health disparities, and I'll have new data after this weekend. So I'll be happy to share that with you.
Great. Anybody else want to get on the stack?
Yeah, Allison Stack.
Anybody besides Allison? Okay, go ahead.
So I just wanted to follow up with that. When you made it, because we always talk about, when we talk about it's like youth, right? But really, we're not that young. Like, we're just in our 20s or early 30s. But children are really negatively impacted by lack of healthcare coverage, as well as like the diet that they're fed by the school, and their parents being in poverty and not being able to afford out of pockets, or in general, not knowing how to utilize the system. Especially if you have a very young family who had children young, they never had health care to begin with, and then they're having children and then they don't know how to navigate the system. So that was a big problem for me. Like, my mom, she knows very well how to navigate the system because of years of use and because my grandmother was a nurse. But my boyfriend's family, they've never utilize the healthcare system. So all the time growing up, they had problems with teeth, problems with ears, long-term damaging problems that will cause long-term damage because they didn't know how to utilize the system, because it's so confusing. And even if they had insurance, it was still so expensive because of out-of-pocket costs and copays. And then there's the added burden of a lot of doctors, they don't spend enough time to explain things to patients. The same thing with people who are in administration. They don't explain enough time so that you don't know what the actual treatment options you have. You're just, oh, here's antibiotics, go home. Or, or here's a treatment. Or my boyfriend got told, because he had what we think was probably a tumor of some sort in his ear, he was told that he should just seek mental health support to get over it. Because that's an accurate way, instead of doing any testing, because testing's too expensive. And he had insurance. So I'm thinking of, like, when young kids not being able to access the healthcare system long-term, particularly teeth, they're being set up for lifetime of pain and suffering, as well as, it's hard to get a job when you're missing half your teeth. By the time you're 12, it's a huge crisis in a lot of places, and there's just not dentists, or things like that. I mean, we haven't even talked about really about dental care or mental health care, which is a completely separate kind of system, that it's even worse than what we have our normal system is. So I would like to hear more about your thoughts as a pediatrician when you worked like that. How was that your experience working with young children, and like how did that shape like you're going into this? Because like I'm a teacher, and like it's really hard to see young kids suffer. So how did that impact you, and what would you advocate us as young people advocating for even younger people? Over.
Yeah, there's so much that you said there. I mean, so right when I started, came out of my residency and started practicing, I was fighting with insurance companies. And what struck me at the time was that they really had no regard for what was best for the children. It was what they could get away with. And so they would, say how many days a child could stay in the hospital. And it had, a lot of times it violated what I felt like was appropriate for that child or for that family. And so I was constantly fighting with the hospital and saying, I'm not releasing this child, until I think they're ready. I also was really frustrated because, whoops, did we lose Allison?
No, she's there, just with video.
Okay, good. It was also really frustrating because I did take time with my patients to talk to them. And in my practice, my office manager was constantly pressuring me to spend less time with them. And one of the last straws for me was when she said, you can only do one well child visit a day because you take too long. And if a patient comes in with a complaint and then they have a second complaint, you can't see them for the second complaint on that visit. You have to make them come back for a second visit. And I just said, no, that's ridiculous. If I have a family here in the office and they're concerned about something, I'm going to want to talk to them about what that is, not make them wait and take more time off work and time off school. So the whole system drives us into having less and less time with patients. It drives physicians. I mean, I don't even feel like physicians now do an adequate physical exam. They barely touch their patients now. And when I was practicing, we could tell a lot, from the physical exam, and not even, then you use tests only based on kind of like what you really needed to figure out what was going on. Now it just seems like it's so much like, go get this test, try this drug. It's really, it's a really low quality system that we have right now in the United States. Yeah, I mean, there's just like so much there. Anytime you want to talk, Allison, happy to talk about some of this. But dental, the other big thing, dental. Yeah, the United States, we have some of the worst dental. And there was a big article, I think it was in the New Yorker a number of years ago, or maybe it was Time Magazine, something like that, about the extent of suffering from dental pain in the United States. And there's a group called Remote Area Medical that literally sets up clinics all around the United States, these giant clinics, and people wait in line all night just to be seen and to get dental care.
Hey, anybody else have want to be on stack?
Brendan Stack.
Go ahead, Brendan.
All right, thank you. So this isn't really a question, as it's more of just a comment. I want to mention the helpless feeling you get when you're tens of thousands of dollars in medical debt. And, there's really like nothing you can do to plan for it. I went through this personally. I was on my parents' health coverage until I was 26. And then like clockwork, when I was 27 and I didn't have health insurance anymore, I started to have medical issues. I started to have seizures. Just out of nowhere, I started to have seizures one day. And prior to that, my whole life, I had been in really good health. And I kind of told myself, well, maybe I don't need health insurance. I'm healthy. And then all of a sudden one day, just something happens to you. And I started having seizures, every 6 to 12 weeks. And every time it's an ambulance visit. And, I spent 12 days in the sleep center, and over the course of a year and a half, I must have incurred, tens of thousands of dollars in medical debt. And you get after a few of these, you feel like there's no way I can ever catch up. I'm incurring debt faster than I could ever even dream to make money. And so you fall to a place where you just feel like, what's the point of even opening my medical bills anymore? You get them and they go in the garbage. I could never even dream to pay them. This is how people end up bankrupt. I'm going to have to file bankruptcy someday. I have no other option. And, it's a really helpless feeling. So there's no question attached. I just had to share my own experience. Over.
Yeah, thank you for sharing that. Sadly, that's a common experience.
Anybody else for stack? Got 17 people here. There's got to be more than Allison and Brendan.
We're the only non-shy ones.
That's true.
Kenny, Stack.
Go ahead, Kenny.
Corey, Stack.
I got you, Corey. That was pretty crazy.
I don't really have a question either, but I've relied on the healthcare, the Medicare, for a while, and I just recently broke my elbow, like my funny bone. I broke my elbow off, it was like 8 weeks ago, maybe 9 weeks ago. I'm about to get back started on work again, and I got all this new metal in my arm and everything, and it's healing up real nice. Dr. DiNicola, he did a really good job. I'm trying to remember the name of the procedure. I couldn't find the procedure on YouTube or nothing like that. He wrote it down for me. But either way, so I've been provided, free healthcare. I feel like I'm listening to everybody's stories right now about healthcare problems and healthcare debt and everything. And I just want to kind of come from the other side where it's actually really good. Because of my low income in the state of Ohio, I've been eligible to receive free healthcare. I broke my arm. I went to the hospital. I took an Uber to the hospital. I signed a few forms when I got there. They got me into surgery a few days later, and I'm on a pretty healthy path to a healthy recovery. So I just want to share with the group that when things work and when we have the power to make the changes, that the talks that we're having right now will be validated in a heavenly way.
Yeah, thank you for sharing that. Yeah, and I know people who have health problems who artificially keep their income down so that they can qualify for Medicaid, because if they made too much money to qualify for Medicaid, they still wouldn't be able to afford health care and they wouldn't be able to live. And yeah, I'm glad that you've got it.
Yeah, I mean, I'm sure there's been plenty of... Yeah, man.
I was just going to say that's another kind of, Allison was asking about the squandering of, youth. And that's another way when youth have to, you can't even start your own business or go into the career you want to go into because you can't make too much money or you won't, get your healthcare needs met.
Okay, I've got Corey next. Anybody want to be on after Corey?
Brendan Stack.
Okay, Corey, then Brendan. Did we lose Corey?
Sorry.
He was kind of,
No, just still at work, so I had to fish my phone out whenever I jump on the call. But yeah, actually, my question, and I guess also statement, is related to what Dr. Flowers just mentioned, and that's so about 5 years ago, literally right after the cutoff for being on your parents' health insurance, I think the first migraine I had was Christmas Eve, and my birthday is 5 days before that. But I was diagnosed with chronic migraine it runs on my dad's side of the family, but I guess to give you an example, the worst recorded incident before me was my uncle, who had maybe 20 a year, and 5 years in, I'm averaging about 70 to 80 migraines a year. And at the time, I was also working temp work, so I had insurance through that, but I only had insurance on weeks that I worked, and the weeks that I didn't work was usually because I was dealing with migraine issues. And then now fast forward a few years later, I'm currently working a job that's one of the few union jobs in Texas. So because of that, I have health insurance that's through the union, and part of the cost is covered through my employer, and I still have out-of-pocket expenses and other issues, but and I don't. I'm taking a job where I probably wouldn't get paid as much if I was working at something in my field, but I'm able to have my medical needs met, including last year where I ended up with an umbilical hernia and out of work for a couple months awaiting surgery. But it was much of the cost of that year was covered and paid for. So I guess what I'm getting at is, one, just a personal anecdote hinting on some of the other things that were mentioned in the last couple of speakers, but also kind of another intersectionality question. What can, is there a way that we can effectively connect this issue with, say, organized labor, the Fight for 15, and other groups that are fighting for income inequality or against income inequality, because this issue of healthcare disproportionately affects the people that are also affected by not making enough money. So that's my, I guess, ask at the end of my story.
Yeah, great.
Also,
yeah,
thanks,
well, thanks.
Also, I was just going to say thank you for coming on the call tonight, and thanks to everybody for participating. It's made the last hour and a half of work pretty enjoyable today.
Thanks. So unions, there are unions that are already involved in advocating for this. There are kind of two groups. One is called the Labor Campaign for Single Payer, and it's kind of dominated by National Nurses United. There's another organization called All Unions for Single Payer, and All Unions has been around for a number of years, and their focus has been to get locals and central councils signed on to endorse HR 676, and there are now about 640 unions, I think, nationwide that have signed on. They provide, tools for presenting resolutions to your union. The Labor Campaign for Single Payer has done some really good work at the AFL-CIO level, because NNU is on the executive board of that. And so the AFL-CIO just met and again, reaffirmed their support for Medicare for All. What we'd really like to see them do is start putting more resources towards organizing for that. And so that still needs to be pushed. But, there are a lot of rank and file unions around the country that have signed on to this. And if you think about it, pretty much in every negotiation with unions, there's some fight over health care. There are a number of unions that are on strike right now around the United States trying to hold on to their health care benefits. And if we took it off the table by having a Medicare for all, workers would be able to actually fight for other things that they need, like safer working conditions and better wages and pensions and things like that. In terms of wealth inequality, this is a huge issue because of the drag that medical costs have on families, and so many families that have to choose between seeking care or paying for their prescriptions or paying for their food or their rent or other things that they need, that we see advocating, or that we see that if we have a national improved Medicare for all, it will actually stimulate the economy from the bottom up, because people will be paying less for health care. They won't they won't have to go without care. They won't have to go bankrupt because of the cost of care. So this is a huge issue in terms of helping out families financially as well. And then, and it's also connected because wealth inequality is one of the biggest drivers of our poor health outcomes in the United States. So that's why we also have a campaign, focused on how to end wealth inequality, build economic democracy. It's called It's Our Economy.us, because this is all that's fundamental as well. We can't, giving people access to healthcare is not going to solve our healthcare problems because there's so many other issues involved. And so I see this as one step on that path, and a very fundamental and necessary step, but there's still a lot of other things that we need to do.
Hey, Brendan, anybody want to be on stack after Brendan?
Allison,
Anyone else? Go ahead, Brendan.
All right, thank you. I would like to ask about the FDA. The FDA has some role in public health care, and I'm curious how the FDA is failing us and what they could do better to make sure people have access to the medicine they need. Over.
Sure, thank you. That's a great question. Again, the FDA suffers from the same problems that we see in other federal agencies, kind of the revolving door problem between industry and the agency, and conflicts of interest. There's a really good psychologist I know, Bruce Levine, who writes a lot about when it comes to kind of medicines that are used in the mental health field, and how there's suppression of, or cherry picking of the studies. And I'm sure this happens in other areas as well, where the pharmaceutical companies cherry pick the studies that they want, that show the results they want, and they suppress the studies that don't show the results. And the FDA is complicit in this, as well as kind of how it's created this whole fast track process. I think it happened in the 90s, of where pharmaceutical companies can pay more money to kind of, get their drugs approved faster. So I see there's a lot of failure in the FDA to actually scrutinize the pharmaceutical companies, to really make sure that what's going on, out for people to use is safe to use. And it's my hope that if we can get a healthcare system where we get that profit motive out, that will help, because a lot of the pharmaceutical research, the majority of the pharmaceutical, not research, but kind of like new entities in the United States, are not actually, or new products, they're not actually like very new entities. What the companies so often do now is they take a medication, they tweak the chemical structure a little bit. They don't have to prove that it's better than what's out there. They just have to prove it's better than nothing. They patent it, they market it really heavily, and this is like, what we're calling innovation. And most of our innovation, when it comes to like really groundbreaking research, is happening through the National Institutes of Health. It's publicly funded. And then that groundbreaking research gets turned over to industry to do the final steps and then market it and make the profit. And so actually Physicians for National Health Program has put together a proposal for just nationalizing our whole pharmaceutical industry. And that makes a lot of sense if you think about it.
Okay, Allison.
Okay, so we talked about a lot of different things, but there's a big connection between all the different ways that the healthcare system kind of fails people because of capitalism. And because of the drive, it's not just a for-profit drive, but like more so than that. Like we are creating customers by creating sick people, and we are not curing diseases or creating cures for things because then there's no customers if everyone's healthy, right? So I work in Korea, and all of my students can easily go to the doctor for free. They can get, pretty major surgeries. They can get medications. They can easily go in for anything. If they feel bad, they can go to the doctor easily. And their parents have no hesitation, and they get really high quality care. Even like I had a student whose father broke both of his legs, okay, in an accident. And that in America not only would he lose his job, the family would lose the house, they would go into bankruptcy, and it would be, the blackest mar on a family's, on a childhood. The child would have to completely rewrite all of their plans for the future based on that accident. So I'm curious as what are your thoughts on like how capitalism and this healthcare system, this for-profit healthcare system, and this abusive healthcare system purposely changes families and children's lives so that they don't pick the careers they want to pick, they don't go to the do the things they want to do, they don't pursue the dreams they want, they can't access the healthcare so that they're healthy enough to do what they want to do. I mean, particularly when we're concerning general healthcare, but mental health care. We are setting up this epidemic of anxiety and depression, and we just call it like, oh, it's millennial syndrome, and it's not. It's a system that was created to abuse people and for profit of a couple individuals at the very top. So my question here is, not only do we need to get rid of a for-profit healthcare system, but we need to get rid of capitalism and how it interacts with that system. And what are your thoughts on how we could actually mobilize youth, both young people who are under 18 as well as people who are 18 to 40, to advocate for that system, I'm not as a socialist, but a non-capitalist healthcare system that actually provides healthcare, actually provides dreams and hopes, and provides people with the ability to do what they want to do. Because right now, I mean, I can't do the things that I want to do because I don't have access to healthcare. I can't take certain risks. I can't go outside. I'm scared to be around people because what if they have a cold and I get a cold and I just have to then suffer? And I'm, at least I know kind of a little bit about healthcare, and I have a family that knows a lot about healthcare, so I can get some help. But for people who don't know anything, they can't tell the difference between cancer and not cancer. They can't tell, hey, this is when I should go to the doctor or not go to the doctor. And they just suffer at home. And that causes long-term, mental health problems and suffering that's completely unnecessary. So my question to you, I guess, or if you have any comments about that, is like how we can kind of connect this bigger issue here of this healthcare system, how it is a perfect example of how capitalism in America has chosen to sacrifice people for profit. In your thoughts? Over.
Yeah, no, you said it very well already yourself. I mean, we are the only industrialized nation, the only nation that has this market-based healthcare system, and it is a perverse system. A lot of the doctors that I work with call it a sick care system, not a healthcare system, because you make money off of people being sick. I know oncologists that are just disgusted with the whole cancer industry, right? And that's a huge industry in this country. And if we want to take cancer seriously, why don't we start doing the things to prevent it? Like, GMOs, or not GMOs, but GMO food that has glyphosate, just it's soaked in Roundup, right? And that causes cancer. The putting industries right into communities where they cause cancer. We just did a tour here in Baltimore City where there was a neighborhood next to an industry, and they found that there were very high cancer rates in the neighborhood. And so the neighborhood organized and got the city to buy their houses out. So what did the city do? They made it Section 8 housing, and they put poor people into those houses, right? Like, you wouldn't do that if you had a system that, public dollars are paying for that care. So, and then the whole thing of, there's an article, we post about this stuff on Health Over Profit. There was an expose done in Seattle the Swedish hospital in Seattle, where a neurosurgeon was making millions and millions of dollars for the hospital, not informing his patients about what their alternatives were, getting them to do this very expensive surgery, and then doing so many surgeries at once, he would have multiple rooms going, that his outcomes weren't that good because he wasn't even able to supervise adequately, what was being done. It was just a whole factory, profit-making factory. A lot of my doctor friends say they feel like widgets in a machine. The hospitals don't care at all about what their input is. They say, just do your job. When I first worked in the early 90s, I worked in a rural hospital, and we did all kinds of neat things there to push the hospital to have new programs that actually improve the health of people in that community. And they wouldn't let me do that now, I'm sure. So, and then, we're talking about the mental health kind of crisis. Bruce Levine writes about when you're in a system that's dysfunctional, to be feeling, the impact of that dysfunctional system is a healthy thing. Like people who can live in this current system and think everything is okay, that's not a very healthy way to be. So yes, this is all connected to, a capitalist healthcare system, a capitalist system that exploits people, doesn't care about them. And I think all of these connections need to be made. And one thing I often tell people is that when we win a national improved Medicare for all, it will profoundly change things, because it will say that we finally have a policy that says that people's lives are more important than corporate profits. We'll have a policy that says that every person deserves the same standard of care, no matter, who they are, what their background is. We'll all be in the same system where we fight to make that system be the best that it can be. And it will empower us to believe that we can actually take on these other fights and win as well, because so many of these fights are connected. So I see this as a really transformative issue to be advocating for. It's extremely there's a lot of movement in it right now, more than I've ever seen in all the years that I've been advocating. So I feel really optimistic that this is something that we can achieve, but we still have a lot of work to do.
Okay, anybody else want to be on stack?
Brendan,
yes,
stack.
Brendan? Go ahead.
I just want to thank Margaret for coming on tonight. This has been really informative. It's really good to have such a knowledgeable presenter here to lay some knowledge bombs on all of us. Thank you.
Oh, thank you. Thanks for inviting me and for being interested in this.
Okay, so I'll make one last call for stack. Anybody wants to get in? Okay, and then I thank you again, Margaret, for coming on. I will have, and we'll get it posted out through the Youth Caucus's social media. Margaret sent me some resources. We'll get this video posted. We'll get some links to Hope and some of the other organizations put out, and hopefully the Youth Caucus can work to put together kind of an action packet. Something we can get in the hands of our members, in the hands of our campus chapters, in the hands of the youth within the locals and state parties around the country, and we can try as a caucus to have this be something that we can work on, that we can have some tangible actions coming out of this. It sounds like we need to have Margaret on again after she goes and comes back with all this new data from her conference.
Always welcome.
Yeah, and so I would not imagine that this is actually not our first healthcare call in our 11 calls we've done since the beginning of the summer. And I would find it hard to believe that this would be our last. Yeah, I think we might have done 2.
Yeah.
So thank you again so much. Before we go, I'm gonna screen share out for a second, but coming up. So coming up, we're moving our calls. This happened to be a 5th Monday, so it fell perfectly in line, but we're moving our calls the second and fourth month, or second and fourth Friday, Monday of the month. Same time, 9:15 Eastern time. You can follow us on Facebook to keep updates. I promise we will be continually getting better with this technology. Hopefully next time we will have the Facebook live stream working, and now I know I need to use 2 monitors when I screen share, so I can still see things. But I can do that. So we're learning on our technology side and trying to make these something that's very engaging to be on, but also something that's a resource after the fact, that we can share these videos out and that people can watch them. And hopefully it's a little more interesting than a webinar from a year ago that you just sit and listen to people talk on the phone. So thank you again, Margaret. If you're on this call and you're a member of the Youth Caucus, pay your damn dues.
Yeah.
YGUS.org.join if you're not a member. You can become a member. Paying dues is $5 a semester, $10 a year. If you're not a member of the youth, we have a Young at Heart program. You can help fund the next generation of Greens. You pay your dues. You help us do this. Keep our organizing space on Space Camp. You help us keep this kind of organizing going on, because as far as I know, this is about the only education program happening within the National Party. These kind of discussions aren't really happening anywhere else. So thank you, Margaret. And coming up, our next call on November 13th will be Ajamu Baraka, Green Party 2016 vice presidential candidate, and a leader in the Black Alliance for Peace. So we're excited to have Ajamu on November 27th, 2 weeks after that. We're going to have the first of our facilitation training. So there's the Youth Caucus has a goal of implementing a team of facilitators to help within the party and within the caucus across the country. And also the goal, this is why we call it facilitation training. One is because we want to move to a model of popular education, where we kind of move away from the empty vessel, person provides information, and really start encouraging people to talk. So, and elevating experiences. So that is the first step. If you're interested in doing what I've been doing today and facilitating a call, come and join us on the 27th. And that is our first kind of train the trainers event for that. And then this afternoon, it was suggested, and we were able to book it before this call, Green Party of the United States political organizer, Adrian Samspero, will be on December 11th. He will be talking about the new emerging kind of green left movement. He's going to be talking kind of about the Nordic Green Left Alliance, the Greens leading the charge in being part of the coalition in Iceland that just took control, and kind of contrasting these new green left orientations that oppose NATO, that oppose imperialism. In Iceland, they want to leave the EU. They're pro-immigrant. They're pro-Palestine. And the same thing in Holland, and kind of looking at these new, unapologetically socialist green alliances. And so and contrasting it against the traditional European model of the Green Party, which has been very successful, but is also, acquiesced to imperialism quite a bit, and there are some flaws there. So on the 13th, we'll have Ajamu Baraka on November 13th. On November 27th, we'll be doing facilitation training. On December 11th, we'll have Adrian on to talk about the rise of the new global green left. And then we'll see you in the new year, because I don't think we'll probably do one on Christmas Day.
Probably not.
But thank you again so much, Margaret. If people want to unmute themselves and say goodnight and thank Margaret, you can go ahead and do that now, and we'll see you all in 2 weeks.
Thank you.
Thanks, Margaret. Bye, everybody.
Thanks so much. Good night.
Have a good night.
Thanks,
Thank you so
Margaret.
much.
We'll see you later. Woo.
Good night, y'all.
Night.
Good night, y'all.
Good night. Night.